Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello, this is Always on EM, the Grand Rounds edition of the Emergency Medicine podcast of Mayo Clinic Emergency Medicine. I am one of the two hosts of the show. I am Venk Bellamkonda, or Dr. Venk. This is a really entertaining show, and you will be so glad you tuned in today, so good on you. Now, in the beginning, we used to do this every time, but decided to do it less often so we didn't bore you all, but it has been a while, so let me just put it out there. If you want to get in touch with our show, specifically Alex or me, you can connect with us on Instagram, YouTube, TikTok, and Gmail. Our contact information to the show and our individual information is in the show notes below, and we would love to hear from you. Our Grand Round speaker today also has a fantastic show that we would highly recommend that you go check out. You may already listen, in fact. It's called The Skeptic's Guide to Emergency Medicine, and it has been a skyscraper on the emergency medicine podcasting landscape for a long time. And that means we must be talking about the unbelievable Dr. Ken Milne. He is a highly decorated educator specializing in teaching critical appraisal to all of us novices on the topic, but he truly can teach us about almost anything, and today he really will teach us about everything. To talk about his many accomplishments before we hear his wonderful talk entitled Old-Fashioned Doctors is an equally legendary physician, Dr. Chris Carpenter, who is a long-standing friend of his and colleague in many endeavors over the years. Take it away, gentlemen, and to everyone listening, enjoy the show.
Well, it's my pleasure to introduce Ken Milne. He has been my friend for 15 years. He told a little story this morning at the 9 a.m. lecture about how we met at a conference talking about evidence-based medicine. He was in the audience, kept asking very hard questions, and we ultimately said in the meeting of the organizers, we can either ask this guy to leave and refund him, or we can bring him on as faculty. And obviously we chose the latter. And we've spent a lot of time together over the years as best friends. He has taught me a lot about life, and if you have not looked at his biography, he's won multiple teaching awards. ACEP's teaching award. He's won CAPE's teaching award. He won SAEM's original FOMED award. He was the inaugural winner of that award. He today is receiving an award up in Canada, but he chose to be here with us instead from the family physicians.
This is the university's award for teaching for the Faculty of Medicine at my university.
University of Western Toronto.
University of Western Ontario, Western University in Boston.
So he's a phenomenal educator. He had this vision 15, 12 years ago that we have to do better, getting information disseminated and making sure that folks can learn how to critically appraise evidence. And he kept talking about something different than the conferences that we all learn, and came up with this idea for Skeptic's Guide to Emergency Medicine, the podcast, and has done something that I haven't seen anybody else do. I mean, Rick and Jerry for years had EM abstracts, but that's a subscription model. You had to pay for it. And Ken gave it away for free, and he did it on a weekly basis instead of a monthly basis. And it's high quality. If you listen to any one of those episodes, critically appraising articles, it's the highest quality, I think, critical appraisal you can get. And I want to differentiate skeptic from agnostic. It's not saying that research is always wrong, that we have nothing to learn. It's show me that this is truth. Show me that you have proven truth here, and I can pull it into my equation of the patient values, my clinical expertise, and the whole body of evidence. And that's pretty unique. If you listen to a lot of podcasts, it's opinion, it's personality, and Ken certainly has personality. But he also has a very intelligent mind. And I think you'll be pleased with what you hear today. You always learn something different when you listen to Ken. He takes perspectives on things that I've personally never thought about. He's helping me to grow as a physician and as a person. So thank you.
Oh, you're making better than having your BFF introduce you. He knows all my flaws. He knows where all the skeletons are, and he still likes me. And so he likes me in spite of my flaws. So again, thank you very much for inviting me to this prestigious institution. Certainly to Fernanda for inviting me to give this lecture at the Mayo Clinic. It is really a really big honor. You probably get sort of insulated in the Mayo and not realize from looking from the outside how you're regarded and how you're regarded very highly. And it is an honor to be here. I hope that you find the talk to be informative, to be a little thought-provoking, to be fun, to be interactive, and there will be prizes. So we're going to start off with some easy questions. Are there any PGY1s, first-year residents, in the audience today? Wonderful. Who are these people? Who are these two people? Who are they?
Those must be the Mayo brothers.
Correct answer. Wonderful. Now we go up in difficulty, right? PGY2. Which one's Will and which one's Charlie? PGY2 question. Anyone?
Charlie's on the left.
Charlie is on the left. That is correct. Who said that? Back in the back here. So you get a kiss from me. Now it's an American kiss, so it's probably worth 1.3 Canadian kisses. Now, the tough question, the PGY3 question. When Charlie and Will were working, they would alternate days. And so they have teams at Mayo that persist to this day that are color-coded. There is Team Blue and there is Team Orange. Which is which? Who's Team Orange and who's Team Blue? Faculty? Do you know? Charlie is orange. Orange, you glad you choose Charlie. That's how I remember that. Yeah, Charlie, who's on this side, on the left, was orange, and Will was Team Blue. And that persists today. And I'll have you know, I have taken 0 Mayo modules. I knew that answer because I did my homework because I'm coming to your home and I want to know about you and understand you so I understand the audience better so we have a better interaction. All right, so now that we're all warmed up with the easy, moderate to hard questions, we're going to get to some general questions. When I say the term old-fashioned, first thing that comes to mind, old-fashioned. Who said whiskey? Must be faculty. Okay, old-fashioned, another one other than whiskey. Fun, old-fashioned. Me? Yeah, old guy. Yeah, anything else? What is it?
Out of date.
Out of date, okay. Anything else? Old-fashioned.
My dad.
Your dad? That's a bit off of that one. Old-fashioned.
Vintage.
Vintage, I would accept vintage or antique, right? Antique. So what about an old-fashioned Christmas, right? Santa sitting in front of a warm hearth. Who said the last one? I've got to get, okay, there we go. How about fashion? Old-fashioned, right? You know, there's all these different concepts and conceptualizations that we have when the term old-fashioned is used. And so this was just a few of them. I'll notice that the first one I picked was old-fashioned, the drink, and apparently it's supposed to be made with bourbon, not whiskey, if you're making it correctly, with a cherry and an orange peel. But there's old-fashioned fashion. There's old tech, right? That's a phone, by the way. That's why you can peg someone's age if they go, call me, right? Because younger people don't call anybody, they text. But if they were, they'd go call me as opposed to this way, right? You've got old technology, old transportation, old-fashioned Christmas, antiques. Well, let's talk about something else here, old-fashioned. Every generation of adults has been critical of younger generations. And this crapping on the generation that comes up behind you is a long honored tradition that goes back thousands of years. And I will not make any claims in my talk that I don't have a reference for. So I have a reference for that. It goes all the way back to 4th century BCE. And there's a wonderful sketch comedy group called Monty Python. These successful old men were sitting around talking about how hard it was when they were kids, how hard it was growing up in their environment. And they're sitting around very successful, drinking some Chateau Chardonnay or something like that. And one man complained that they lived for 3 months in a paper bag in a septic tank. They used to have to get up at 6 in the morning, clean the paper bag, eat a crust of stale bread, go to work down at the mill for 14 hours a day, week in and week out, for 6 pence a week. And when they got home, their dad would thrash them to sleep with his belt. And another gentleman says, luxury. Right? And it's just one-upmanship, right? If you've never seen the skit, just put 4 Yorkshiremen into YouTube, and it's about a 3-minute skit about them escalating about, oh, how hard it was, had to walk both ways uphill to school in the snow, that kind of stuff, right? But rather than playing that, this is my reference for the thousands of years that the existing generation looks down their nose at the generation coming up. And so this will be a 90-second clip.
At this point, Ken is going to show a video where there's a stack of sheets of paper that has text on them, where there is a date, a quote, and then an attribution. I'm going to read them off to you so that you can follow along. Let's begin. The history of adults blaming the younger generation. 2001. They have trouble making decisions. They would rather hike in the Himalayas than climb a corporate ladder. Article in Time magazine. 1993. It's the first generation in American history to live so well and complain so bitterly about it. Article in the Washington Post. 1951. Many young people were so pampered nowadays that they have forgotten that there was such a thing as walking. Article in Falkirk Herald. 1933. Women painted like prostitutes, throwing off every kind of social restraint. All of these things to prove that now the vulgar mob that gives the tone. Hour of Decision, Oswald Spengler, as translated by C.F. Atkinson. 1925, an attitude on the part of young folk which is best described as grossly thoughtless, rude, and utterly selfish. Article in the Hull Daily Mail. 1843. Girls who drive coal carts, ride astride open horses, drink, sweat, fight, smoke, whistle, and care for nobody. The morals of children are tenfold worse than formerly. Anthony Ashley Cooper, the 7th Earl of Shaftesbury, a speech to the House of Commons. 1790. The free access which many young people have to romance, novels, and plays have poisoned the minds and corrupted the morals of many a promising youth. From Memoirs of the Bloomsgrove Family by Reverend Enos Hitchcock. 1624. Youth were never more saucy, yet never more savagely saucy. The ancient are scorned, the honorable are contemned, the magistrate is not dreaded. From the Wise Man's Forecast Against the Evil Time by Thomas Barnes. Between 1330 and 1332, modern fashions seem to keep on growing more and more debased. The ordinary spoken language has also steadily coarsened. Sura Zuragusa, Essays in Idleness, Yoshida Kenko. Circa 20 BC, our sires' age was worse than our grandsires'. We, their sons, are more worthless than they, so in our turn we shall give the world a progeny yet more corrupt. From Book 3 of Odes. Horace. 1st century BC. The beardless youth does not foresee what is useful, squandering his money. Also attributed to Horace. 4th century BC. Young people are high-minded because they have not yet been humbled in life. They think they know everything and are always quite sure about it. Rhetoric by Aristotle.
Yeah, there's that last one. Young people are high-minded because they have not yet been humbled by life. They think they know everything and are always quite sure about it. That could have been said today, right, about young people. When my daughter came home from school the other day, she had ripped jeans. And I said, there's 2 possibilities, honey. You were attacked by coyotes, or I don't understand fashion. Why would you pay so much for jeans that were shredded all the way down the front? Apparently, that's the style, right? So older generations have always looked at younger generations with criticism. But let's talk about old-fashioned doctors. because that's the title of my talk, Old-Fashioned Doctors. And this was a description of an old-fashioned doctor by Isaac and Fitzgerald, published in the BMJ in 1999.
It reads, "The more senior the colleague, the eminent physician with the white hair and balding patch are called the halo effect. They place less importance on the need for anything as mundane as evidence. Experience, it seems, is worth any amount of evidence. These colleagues have a touching faith in clinical experience, which has been defined as making the same mistakes with increasing confidence over an impressive number of years." End quote.
And these two authors were describing alternatives to evidence-based medicine. And one of their alternatives was eminence-based medicine. And this article was a funny article. Their tongue was firmly in their cheek when they were talking about this. But this is what they said about their more esteemed and elderly colleague, that eminent physician had that halo effect, thinning hair, a crown of grayness around it like a halo, and that they didn't really rely on things as mundane as evidence. They relied on their clinical judgment and clinical experience and, quote, making the same mistakes with increasing confidence over an impressive number of years. Old-fashioned doctors. And so my talk actually came about, the reason I'm doing this talk, how it came about, was this article that was published by Dr. Herbert Fred. Now, he wrote this opinion piece in 1998 in the Journal of Hospital Practice. So to understand this, Dr. Fred was born in Waco, Texas, small town in Texas. He went to medical school at Johns Hopkins. He did his internal medicine at the University of Utah and then served in the U.S. Air Force. Pretty apropos after Memorial Day. And then he went to teach for nearly 6 decades of internal medicine at Baylor College of Medicine and the University of Texas Health Science in Houston. Now, in this article, Dr. Fred was commiserating about all you young people, right? And he was saying in the 40 years at that point, in the 40 years I have been a full-time medical educator, much has changed regarding how we teach our students and house officers. As a consequence, I now confine myself to teaching basic medical principles, principles that should never change, But even so, today's trainees tell me what I say and do is old-fashioned. So being on the older side, being on the more mature side, because that's what I call older people, more mature, I thought that sounded like a bit of ageism from his students. Oh, look at what you're doing. You're so old-fashioned. You're so old school. But I can appreciate that when he wrote this article, if you were a student, you would think there's some ageism going the other way, complaining about the students. And so he wrote this one-page article and had a dozen things defining what he thought it meant to be old-fashioned. And so I'm not going to go through all of them. You know how many I'm going to go through? 10. My favorite number, my second favorite number, right? I'm going to go through 10 because it's twice my favorite number. And so we're going to go through 10 of those. Now, when reading this, it does have a bit of a okay boomer vibe to it, right? Dr. Fred made, these dozens of complaints about, students calling him old-fashioned, but he concludes with, if I am old-fashioned, if so, then I'm proud to be old-fashioned. And I believe that if more doctors today practice medicine the old-fashioned way, what students were telling him, our profession might regain some of the nobility and respect it once enjoyed. Well, I posted this article to social media. Has anybody been on social media? It can be a bit of a dumpster fire, right? Now, most people saw this article and thought, yeah, there's some real truisms there. There's some axioms. There's some truth to what he's saying. And I got a lot of emojis and a lot of smiley faces, but there was a small minority that was not too happy with what I said. And they were concerned that it expressed this sort of ageism and it was crapping on a younger generation. So I'm going to go through 10 of his comments and talk and try to explain that it's not about old fashion. It's not about new fashion. It's about timeless axioms of how we can behave with patients and how we can conduct ourselves. And it has nothing to do with how old you are or how young you are. And so I think this dichotomy of old versus young is a false dichotomy. And so number one, let's go through those. This is number one, time with patients. Dr. Fred said, it is because old-fashioned doctors spend whatever time it takes to obtain a good history and physical examination. Seriously, Dr. Fred? Don't you think that most of us would want to spend more time with most of our patients? Not all of them, but most of our patients. We'd like to spend a little more time, slow down the pace, take a breath, listen more, and have a longer conversation. Now, this image is from this image is from a long time ago. You see that single male white physician leaning over the bed of a child. Well, back in the 1960s, when Dr. Fred was practicing, the emergency room was a room, and there was no specialty of emergency medicine. That didn't come out until the 1970s. And so a physician could sit down in the room with only one patient who was in the whole facility. This is different than today. This is an updated picture. This is our working environment. So is it a problem with younger physicians that they're not spending the time that they actually probably want to spend with their patients? Or is it the fact that we have these insane metrics that drive us to have all of this efficiency? Or as I say on my podcast, meet them, greet them, treat them, and street them, moving the meat, right? We got to get them in, get them out, and we got to do it quickly, right? To meet all these metrics. And then on top of that, we had this little global pandemic called COVID-19, which I represent as a dumpster fire. And now the healthcare system, the entire healthcare system, at times seems like it's signed out to us. Whether that be primary care, go to the emergency department. Post-op complications, go to the emergency department. Mental health problems, go to the emergency department. Substance use disorders, go to the emergency department. And it goes on and on and on. And so when Dr. Fred was saying, well, you just have to spend more time with your patients, I think we would all like to do that. And it would be a sign of a good physician. And then Dr. Fred went on to say about patient records. Is it because old-fashioned doctors routinely seek all the patient's previous medical records and not just pull up their last discharge summary? Well, previous records, I don't know if the pediatric emergency physician is here, but my father-in-law was a pediatrician for about 40 years. He had an entire family on an index card, right? So it was pretty easy to get the medical history. Well, there it is, right? These medical records with EHR have just become so vast, so bloated. The EHR was supposed to improve our lives. Anybody here think that have a better life because of the EHR? You do? Good, Russians. I think I'm scared of her. I'm more scared of Fernanda. With this, this problem of note bloat is what it's called. It is just phenomenal how much information is there. And in fact, if anybody's interested in narrow artificial intelligence, they're using large language models in some places to try to search these huge medical records just to find the signal in the noise, to find the needle in the haystack. And so when I log on and I'm looking up and a patient's come in and they've got these complicated medical problems, I look at their last admission and discharge summary. I couldn't possibly, if I'm going to be efficient, go through their entire medical record. It would just be impossible. And EHRs, of course, have been identified by physicians as one of the top reasons for burnout. People stay late, they stay after their shift, and they're not doing direct patient care. What they're doing is documenting what they did. And I understand that there's medical legal reasons driving this, and I understand that there is also billing reasons to do this because you have to have billers and coders to capture everything you did. And then how about sophisticated and expensive tests? This is number 3. Is it because old-fashioned doctors do not order sophisticated, expensive tests when simpler, cheaper procedures can supply the needed information? I mentioned this morning that I had worked for over 2 decades at a critical access hospital that doesn't have a CT scanner. Guess how many CT scans I tended to order? Hardly any. It's pretty easy not to order tests when you don't have them. And if there's all these barriers to get them. And so in Dr. Fred's time, there may not have been sophisticated, expensive tests. Does anybody remember? I'm going for an older question, right? Does anybody remember how the diagnosis of diabetes mellitus used to be made? Taste the urine. Yes. Who here wants to go back to sipping urine? Look at that. It's got clarity, nice legs, a little nutty aroma. You know, like, do you really want to go back to doing that?
No, who remembers when we didn't have gloves?
Yeah, gloves in the room, like the 1980s and 90s with the AIDS epidemic, people started wearing gloves. We used to do suturing barehanded, minor procedures were barehanded, right? And so now, who here has done a peritoneal diagnostic lavage recently? Yeah, right. Like, it's not something we do. Now we have POCUS. We have the stethoscope of the 21st century. We have these new technologies. And I know CT scans aren't that new, but boy, they are better than plain films at diagnosing C-spine injuries, head injuries, pelvic injuries, abdominal injuries. And sure, we might be a little quick to pull the trigger sometimes on a CT. And there is over-testing and over-diagnosis. That's a real thing. But it has improved our ability to diagnose correctly. And I often say that the emergency medicine alphabet is no longer ABC, right? That's what I was taught when I went airway, breathing, circulation. That was the mantra when I was going through 30 years ago. ABC of emergency medicine. It's now ABCT. All right. And how about brains and heart? This one actually irked me a bit. Is it because old-fashioned doctors use their brains and their heart and not an army of consultants to manage patients? I think this comment misses the mark by Dr. Fred a bit. In 30 years of practice, I have seen wonderful, caring physicians who are young, who don't rely on an army of consultants. And at the same time, I have seen the opposite. So, faculty, do you think you have caring residents that use their hearts and their minds to take care of patients? Absolutely. Residents, and I'm not talking about your immediate faculty. Have you ever come across, maybe somebody on off service, let's do it that way. Anybody come across someone off service who's maybe not as kind with patients? And you're going, really? Now, I guess this is at the Mayo, so maybe not. But certainly in my career, I have seen young physicians that are fantastic, caring, brilliant, smart, and have taught me. And I've seen older physicians who are not as caring and are a little rough, and a little gruff, and a little less empathetic than I would have expected them to be, and don't have the knowledge base I'd hoped them to have. And so I'm not dichotomizing, I'm just saying what matters is you, and not your chronological age. So I think you missed the mark on this one again with regards to saying old fashioned versus new fashioned. There's not a fashion here. There's just using your hearts and using your brains to take care of patients. And so you can be a caring, thoughtful physician no matter what age you're at. And then here's the one about treating patients and not numbers. Is it because old-fashioned doctors treat patients and not numbers? I agree, we should be treating patients. We should be treating them as human beings, as a person with agency, with value, and with respect. Here's a little quiz, because I'm in America. What's the 14th Amendment? I'm waiting. I'm expecting from you, Dr. Leff. Dr. Leff, what's the 14th Amendment? It was? Say it louder.
I'm not gonna say it.
It was, I'll say it then, if you don't feel comfortable saying it. It was when Black people were no longer recognized as property. She did say slavery. Yeah, no, I know. I just think she didn't want to say slavery out loud, so I tried to rescue her, but then you just threw her under the bus. Yeah, Dr. O from Ottawa. So 14th Amendment. 14th Amendment recognized Black people no longer as property. Wonder how those physicians treated people back then. Did they treat them as patients or numbers? I mean, that's 150 years ago. I sat through some of your talks this morning. Are there racial disparities and inequities still in the House of Medicine?
Yeah.
150 years later. But I have more support for my thesis about not treating patients as numbers. And just because you're old fashioned, does that mean you treated people as a human being or as a patient or as a person? What was the 19th Amendment? See, I did my homework. I'm coming into your house. What was the 19th? Suffrage. Yeah. Women got the right to vote. Do you know when it was?
1920,
1920. Yeah, 1920. Damn, good. 100 years later. Does
1849,
what's that? Sorry?
New Zealand.
Yes. Yeah. We're not here to point fingers. But yes, other countries changed at different paces. See how Canadian I am? Sorry about that. 100 years ago, 100 years ago, are female patients still treated differently at times? Do we have evidence with regards to cardiovascular disease? Do we have evidence with regards to oligoanalgesia? Do we have there's lots of lines of evidence that we have not been treating certain people as patients, as a person. So 1973, I'm going to give you a number this time. 1973, about 50 years ago, the American Psychiatric Association removed this diagnosis from the DSM-2, the Diagnostic Statistic Manual 2, as a mental illness. What was it?
hysteria.
Not hysteria, but that's my next point. Damn it. It must be all Rebecca's are great.
It's homosexuality.
Rachel, sorry. Damn it. Rachel, that's Rebecca.
Homosexuality.
Homosexuality, exactly. Up until 1973, homosexuality was considered a mental illness. And I'm not trying to be, looking down my nose. Cultures change and societies evolve and stuff like that. But 1973, that's not too long ago. And some of us are old enough to have practiced through the 80s and 90s. And I have to say that gay men were not treated as patients. They may have been not treated as numbers, but they certainly weren't treated as patients. They were shunned. A lot of people were blamed. Not something I'm proud of as being part of the profession. So we should treat people as patients, not as numbers. Now, how about now? How are we treating trans lives? How are we treating non-binary people? Are they discriminated against? I heard a talk this morning that they were. And that's why I said I had this as part of my talk. That was you, right? Yes. You were the 10th talker, correct? The 10th talk. My next podcast is on transgender issues in the emergency department. And we need to continue to learn. We need to continue to think about these things and reflect on how we treat people. And how we treat people, I like to use, this is for the leftist, the left over there. It's okay. I'm the pink part of the, above the continent or above the US. We're a big pink part of the map. So I try to use The Veil of Ignorance by Jonathan Rall. How would I like to be treated? But you don't even know if you're a have or a have not. I don't know if I'm in Guyana or if I'm in the US and if I'm at the Mayo Clinic with this phenomenal trauma center or I'm there. That's how I want my society to be set up. Those are the moral choices I want to make based on the veil of ignorance that I don't know, so that we treat all patients with kindness, no matter what size, shape, color, or how they identify. I don't care. And it's because I care so much that I don't care how you identify. I'm not there to judge. I don't want people judging how I live and my choices in life. I'm not there to judge. I'm there to care for people. But let's get to number 6, a pill for every ill. Is it because old-fashioned doctors do not blindly administer a ton of drugs in an attempt to alleviate every possible ill? giving out the medicines, right? To everything. This is another case of it's pretty easy not to give a whole bunch of drugs when all you can prescribe is aspirin, right? Like 100 years ago, 1899, so more than 100 years ago, 125 years ago, aspirin was patented. Now, they've known about the benefits of aspirin going back 4,000 years and willow trees and salicylates and all this kind of stuff. But it was patented in 1899. But think about having a heart attack in Dr. Fred's time, and what could we offer them? This will be a Fernanda question. Mona. Do you know what Mona is? Do you know what Mona is? Who can help out Fernanda? Because it may have been a North American thing. Morphine? Mona. Morphine, oxygen, nitro, and aspirin. You can share them. Yeah, Mona, right? That's what you could offer patients. You know, a middle-aged 45-year-old man comes in with a STEMI. He gets Mona. Because it was usually a 45-year-old to 50-year middle-aged man, smoking and drinking, you know, lots of lifestyle risk factors and stuff like that. What do we give a person with a STEMI now? We give dual, calf. But they also leave with a whole bunch of pills, don't they? Now, I've got a nice meme here to remind me of this. This is when people come in and say, yeah, do you have any health history? No, not really. Oh, can you tell me what meds you're taking? And they all come out. Right? But if you have a STEMI now, you're probably leaving with dual antiplatelet therapy, a statin, an ACE inhibitor, a beta blocker, plus aspirin and plus or minus nitro, right? To be used. What's the life expectancy of that person who had the STEMI in 1950 compared to now? A lot better. And so sure, is there over-diagnosing and over-treating? Yes, of course there is. And we have to find that Goldilocks zone. But look at this life expectancy chart for the world. I'm not saying medication and a pill for every ill is responsible for all of that phenomenal dramatic increase. Bye, Rachel. She gets her 2 chocolates and a couple of kisses and she leaves. Hopefully you got that on video. I'm sure that'll be a meme, Ken blowing a kiss to Rachel. But, you know, really, when it comes to this, there's been such an amazing progression. And we basically doubled life expectancy in the last 100 years. So do you want to go back when we didn't have some of these amazing medications? Do we want to go back to an era where we didn't have vaccines? Because the average life expectancy at the turn of the century was probably in the mid-40s. And now it's 80. It's a huge increase. Do we want to go back to when we had children who got type 1 diabetes and we didn't have insulin? Insulin is an amazing drug. Amazing drug. Metformin, Flozins, GLP-1s. How about antipsychotics like lithium? Made a huge difference. Birth control, right? In the 1960s, birth control came out and gave women more autonomy over their reproduction. And asthma drugs, beta agonists, inhaled corticosteroids. Modern medicine has contributed dramatically. So yes, you can complain, oh, look at these young doctors. They're just writing scripts left, right, and center. And I say it like that. I don't know how Dr. Fred talked. And I'm not being critical of Dr. Fred. I'm just talking like that. Okay. What we want to do is make the right diagnosis and give them medication that's been demonstrated to improve their quality of life and their maybe life expectancy, but to improve a patient-oriented outcome, not just giving them a prescription for the sake of giving them a prescription. That's different. All right, now here's some American questions. All right, so this is about intervention bias. Is it because old-fashioned doctors recognize that doing nothing is at times doing a lot? Which president is this? Oh, I got the middle one in the back wearing blue. Now, does that mean you're on Team Will? Or does that mean you're in diagnostic imaging or a tech? Because blue means something here, right?
PA fellow.
PA fellow, okay.
Or AP.
APP, an advanced practice provider. All right, so this is George Washington. You know what he died of? He got a throat infection. He went out for a ride on a wet night, stayed dressed in his clothes that were wet, and then woke up the next morning or something like this. Had a sore throat, got a fever. They called the local physicians and stuff like that. And over the next 21 hours, they bloodlet him 40% of his blood volume. So I didn't include this in some of the objectives for today, but as clinical pearls, if somebody presents with sepsis, it is not the goal to remove 40% of their blood volume. Okay? And they did, and he died within 21 hours. They thought it was epiglottitis. There's some back and forth on what exactly the agent and condition was, but thought it was epiglottitis. But they bloodlet him, right? There was intervention bias. That's an old-fashioned thing, right? Bloodletting, that seems old-fashioned. Does that make it right? No. What makes it right is if it has a patient-oriented outcome of benefit. And so there's thoughts that maybe if they'd done a tracheostomy, he would have survived. I don't know, but he died in 1799 after 21 hours. He also got, I looked this up, he gargled with molasses, vinegar, and butter. He inhaled steams of vinegar and hot water, and his throat was prepared or swabbed in a preparation of dried beetles. And we look back at this and laugh, right? But this was the top of the line back then, right? People, there was 4 evil humors, and there was bloodletting, and all of that kind of stuff. But we wouldn't be like that now, would we? We wouldn't have intervention bias. Which president is this? W? Who said W? That's George, another George W. Bush. And so he was, George Washington died at age 67. George W. Bush at age 67 had one of these, VIP presidential checkups, right? Where they take really good care of these VIPs. And in there, they discovered he had, despite being a very fit man, very active man, asymptomatic coronary artery disease. So what did they do? Stented him. Who said stent? Yeah, they stented him. They put a stent in there. Is there good evidence, high quality evidence that stenting is any better than maximal medical therapy? No, but there was intervention bias. And so when they're complaining in this part of the thing, as old fashioned doctors, we recognize not doing something. Intervention bias has nothing to do with being young or old. It has to do with a psychological situation of human beings that we have a bias that it's better to do something and be in action than not doing something. And that can be learned at any age, that sometimes you have to stand back and not do something, but stand there. And I learned that from my mentor, Dr. Jerry Hoffman. And that's wisdom that doesn't necessarily come with age. It just comes when you realize that when you do something, it should be in the interest of the patient based on good evidence and logical arguments, not just do it for doing something's sake. All right, now I'm supposed to identify 3 logical fallacies as part of my objective, so this will be one of them. Natural history of the disease. Who is the person on the right? Nope, not Socrates, but it's a philosopher. Aristotle, because we're talking logical fallacies. And he was the first one to write his first dissertation. Who said Aristotle? You did? We talked about Octavian. So yeah, and he had 13, right? And there's formal fallacies, formal logical fallacies, and informal logical fallacies. And so in this one, with regards to the natural history of the disease, is it because old-fashioned doctors understand that patients will get well despite what we do, not as a result of what we do? Well, I've been working in the emergency department, and I've seen some doctor who may be older than me, maybe not, who has made the post hoc ergo propter hoc fallacy. Ooh, this lecture just got really, Does anybody know what that Latin means? I'll say it again. Post hoc, what do you think that means? After this, ergo, therefore, proctor hoc, therefore, because of this. So just because you did something and something followed it, that something that followed was due to this. And I see people make that mistake all the time, that logical fallacy. Somebody comes in writhing in pain. You diagnose them, they got renal colic. We give them medicine while they're writhing in pain. Let's say it's ketorolac, 10 milligrams IV. And 15 minutes later, they're feeling better. Was it the ketorolac? Or what do we call that medical condition? Renal colic. It comes and goes. And when the person is screaming and moaning and in the most distress, we're the most likely to be there at the bedside giving them medication. And because it ebbs and flows, what's the natural history of the disease? that the spasm will go away, the pain will subside, but then it may come back again. But we attribute, oh, it must have been something we did. And that's not necessarily true. And I've seen young doctors and old-fashioned doctors make this same error. So that's one of the logical fallacies. There'll be two more. There's a quiz. We're getting near the end. This is probably one of the most important ones I wanted to bring up. This is about kindness. And we talked about that this morning because medical legal, right? You said, is it because old-fashioned doctors realize that good rapport with their patients is their best protection against lawsuits? So this one does speak to me about kindness. And we should be kind to all our patients, staff, and even to ourselves. If one of the secondary outcomes is you're not as likely to get sued, great, but that shouldn't be the primary reason for having good rapport with our patients. And I like this one. Be kind to everyone you meet because they're fighting a hard battle that you probably know nothing about. I could have shown you a Venn diagram of a big blue circle and a little dot in there. And the big blue circle is the patient you're taking care of. And that little dot, maybe it was like that basketball and that, what do you say? It was 6 millimeters. Where's our NASA guy? It was 6 millimeters, a little piece of dust, 6 millimeters. That's what we know about our patient, right? We know only a little thin slice about their life and we're judging their decisions. And so, we really need to be careful about this. I do like this quote though, because I'm at 40 years now. So this is Aldous Huxley, sorry. And it's a little embarrassing. And I've been practicing I've been doing research for 40 years. So after 45 years of research and study, the best advice I can give people is to be a little kinder to each other. And that's not old-fashioned. That's not new-fashioned. It's just an axiom of truism, a timeless piece of advice. You know that first patient I saw on my very first shift in emergency medicine? I should be kind to them. And on my last shift, and the last patient I ever see in my career, I should be kind to them. It doesn't matter whether you're old or young, you should be kind to the people we're caring for. And the last one is, I like this one because this one goes with skepticism and humility. I don't know. Is it because old-fashioned doctors are aware of their own fallibility and can never be afraid to say, I don't know? Maybe. Maybe as an older physician, you have privilege. And it's okay to go, well, I made that mistake, or I don't know, right? Can you imagine residents walking around going, yeah, I killed that patient and I don't know this stuff, right? They might be in more jeopardy, right? So there might be some privilege going on there with regards to saying, I don't know. I think it's our responsibility as faculty and as attendings to create an environment where it's acceptable to say, I don't know. It's our job to find their knowledge gaps. And I think it's a little unrealistic to expect trainees to know everything and answer all of our questions correctly when we're asking them questions. Medical knowledge has expanded at such a huge rate in the last few decades. And now I have to carry around an accessory brain, right? To look up things. And I look up things regularly. And I say regularly on shifts, when residents ask me about something, I go, I don't know, let's look that up. Let's figure that out. And it's okay to say that. And so I'd rather a resident say, I don't know, than say, I do know, and they pretend to know, and they don't know. And so let's make it a safe space for people to learn. And let's make it a safe space for them to explore their knowledge gaps. And so that they can say, I don't know. And this is one of my favorite Richard Feynman quotes. We need to teach how doubt is not to be feared, but welcomed. It's okay to say, I don't know. And when I've been shown to be wrong in a certain situation, or my thoughts have been wrong, or my position has been wrong, I don't take that personally because none of my positions define who I am. I don't define myself by my medical positions. And so it's really liberating to get to that point or think about it that way, because you know what? I have a chance to be less wrong in the future. And so I thank the individual that has pointed out my error and my mistake or my flaws in thinking. And I thank them quite a bit. And it's usually a pharmacist. They catch that. Usually, yeah, that was for you, Allie. That was so much for you. But I'm like, oh, well, thank you. I didn't know that. I have learned today, and I learn on every shift, and it's really great to do that. So I'm supposed to finish, I'm supposed to have 3 logical fallacies. So I'm just going to put the appeal to tradition. So when it's assumed that that something is better or correct simply because it's older or has traditionally been done that way. You know what makes it right is if it works. There's a satirical comedian. Now I'm going to forget, Tim Minchin. And you know what we call alternative medicine that works? Medicine, right? And so I don't care if it's an old thing or a new thing. What I care about is, does it work? Does it have good evidence of efficacy? Does it have a good evidence of a patient-oriented outcome? Bloodletting didn't turn out so well for most cases, right? So I'm not using it. And there's lots of examples of things that don't necessarily work. But the flip side of that, and this is the opposite one, is the argument ad novitatem, and I probably pronounced that wrong, claiming that something is new or modern is superior to the status quo just because it's new. And maybe you have to be through enough cycles to realize this through, a new drug will come out and everybody's, whoa, isn't it great? And then in, 5, 10 years in, yeah, it's pretty good. And then 5 to 10 years after that, a new drug in a similar category, wow, this is great. And the other stuff is crap, right? And see that cycle of evolution. Just because it's new doesn't make it better. What makes it better is if it's better. So I'll conclude at the end of the day, it's not about being old-fashioned. I'd like to get away from that ageism of old-fashioned. It's not about being new-fashioned. It's more about being on what I call team patient. It starts with patient care, it ends with patient care, and our decisions should be centered around what's in the best interest of our patients. And so some things are just timeless. Providing patients with the best care based on the best evidence, and kindness is timeless. Thank you.
Wasn't that awesome? Ken, you are the man. Folks, check out his show. Again, it's called The Skeptic's Guide to Emergency Medicine. The link is below. Also, if you want to see the visuals for this talk, you can watch the entire thing again on YouTube. His channel is linked below. Find all our contact info, social media contacts, everything in the show notes. If you can, like, comment, and follow our show on whatever platform you're listening to us, and join us again on August 1st for the next installment of Always on EM. Thank you for listening.
The Always on EM podcast.
Emergency Medicine Grand Rounds.